Hi everyone, our subject today is fever of unknown origin in pediatrics. Basics. Fever of 38.3 Celsius is defined as fever. Fever of at least 8 days in duration, no apparent diagnosis after an outpatient or hospital evaluation that has included a thorough history and physical examination and initial lab assessment. The three most common etiology categories of fever of unknown origin in children are infectious, rheumatologic, and oncologic. The most common infectious are Epstein-Barr virus infection, osteomyelitis, and UTI. Approach to the patient. Phase 1. Document fever through history and physical exam. Determine whether constitutional symptom like growth failure, developmental arrest, suggest a serious underlying disease. Create a broad differential diagnosis. Begin initial laboratory evaluation while tolerating the cadence of evaluation to patient severity of illness. Phase 2. Begin invasive study to seek rarer form of fever such as lymphoma, brucellosis, and subacute bacterial endocarditis only if clinically indicated. Phase 3. Re-examine patient, consider additional testing and reconsider causes such as systemic JIA, sarcoidosis, and factitious fever. Repeat history and physical exam combined with the result of previous testing should guide the subsequent evaluation. History. Fever intermittent with a high spike and rapid diffusiveness like in pyogenic infection, tuberculosis, lymphoma, and JIA. Remittent with the fluctuating peaks and a baseline that does not return to the normal in viral infection, infective endocarditis, sarcoidosis, lymphoma, and atrial myxoma. Sustained with the little or no fluctuation, typhoid fever, typhus, brucellosis, and many other infections. Relapsing with the intermittent period, more than 1 day, without fever, malaria, rat bite fever, Borrelia infection, and lymphoma. Recurrent episode over period of more than 6 months duration in metabolic defects, CNS dysregulation of temperature control, periodic fever syndromes, and immune deficiency. Temperature of 42 Celsius or more are most often non-infectious in origin. Question temperature and how they were measured: tympanic, oral, axillary, rectal. Significance: as many as 50% of children referred for evaluation of fever of unknown origin have multiple unrelated infections, parental misinterpretation of normal temperature variation, or complete absence of fever at time of evaluation. Parents are sometimes told to add 0.5 Celsius correction into a temperature measured in the axillary to better approximate the core temperature. Such practice may further cut the evaluation of the febrile child. Question about ethnicity. Significant: some hereditary periodic fever syndrome have ethnicity predilection. Consider familial Mediterranean fever in Armenian, Arab, Turkish, sporadic Jewish, hyper IgD syndrome, Dutch and French, and tumor necrosis factor receptor associated periodic fever syndrome, TRAPS, in Irish and Scottish. Exposure to animal include household pets, domestic animal in the community, and wild animal can cause zoonotic infection. Unpasteurized dietary products, contact with the animal in brucellosis, consumption of hunting meat, raw meat, or raw shellfish, brucellosis, toxoplasmosis, tularemia, hepatitis, contact with the urine of infected animal, rats in water or soil in leptospirosis, cat or dog bite in Pasteurella infection, contaminated food, undercooked meat, poultry or eggs in Salmonella, skinning, dressing or eating infected animal, squirrels, rabbits, hares, and muskrats in Tularemia, inhaling aerolized dust contaminated by parturient cat or consuming unpasteurized contaminated milk products in Q fever, pica ingestion infected cat feces in Toxocara infection and toxoplasmosis, tick bite in Rocky Mountain spotted fever, ehrlichiosis, tularemia, tick-borne relapsing fever, or Lyme disease. Travel to or coming from endemic area in Rocky Mountain spotted fever, Southeast Asia, West and Southwest Pacific in scrub typhus, Africa, Southeast Asia, Central South America in malaria. Question: medication, including over-the-counter medication and eye drops, drug fever, atropine, induced fever, methylphenidate, and antibiotic, especially penicillin, cephalosporin, and sulfonamide, diitrophenol, and uncouplers of oxidative phosphorylation, anticonvulsant, allopurinol, and other chemotherapy agent, nitrofuranation, phenothiazine, drugs with anticholinergic effects, atropine, antihistamine, and sympathomimetic effects, cocaine, epinephrine, amphetamine, are among the more common causative agents. Discontinuation of the drug followed by disappearance of fever is suggestive of drug fever, although sometimes fever persists days to weeks as a result of slow excretion of the drug. Question: change in behavior or activity significant, brain tumor, TB, Epstein-Barr virus, Rocky Mountain spotted fever. Question: well water ingestion significant, giardiasis. Associated symptom: weight loss, excessive bruising or bleeding, limping, bone pain at night, neoplasm, joint pain, worse in morning, weight loss, eye complaints, rheumatological disease. Past medical history: lymphoma, rheumatic fever, HIV infection. Physical examination: absence of sweating in the presence of elevated or changing body temperature. Consider dehydration, anhidrotic ectodermal dysplasia, familial dysautonomia, or exposure to atropine. Purulent discharge in the nose or posterior pharynx, erythematous and boggy nasal mucosa, tender on percussion over sinusitis, ear pain, hearing loss, ear discharge, vertigo, abnormal tympanic membrane, bulging, redness, air fluid level in otitis media, cardiac murmur, often in new onset in infective endocarditis, sign of respiratory distress, tachypnea, hypoxemia, retraction, nasal flaring, grunting are more specific than fever or cough for pneumonia. Skin finding: petechia in infective endocarditis, bacteremia, viral and rickettsial infection, as well as vasculitis or oncological disease. Rash begin on the ankles and wrist and spread to the palm, sole, and centrally in Rocky Mountain spotted fever. A primary cutaneous papule or pustule develop 3 to 10 days after an animal contact at a site of scratch or bite, cat scratch disease, Bartonella, Ishkar, tularemia, scrub typhus, macular salmon pink rash in juvenile idiopathic arthritis, malar erythema, systemic lupus erythematosus, palpable purpuric lesion, vasculitis, like in polyarteritis nodosa, urticarial and or sporangious macular rash and band of erythema at the lateral aspect of the hands and feet, serum sickness, erythema nodosum, infection, malignancy, JIA, SLE, and inflammatory bowel disease. A seborrheic rash can indicate histiocytosis. Spare hair, particularly of the eyebrow and eyelashes, and hypohidrosis may suggest anhidrotic ectodermal dysplasia. Eye problems: red weeping eyes, connective tissue disease, especially polyarteritis nodosa, palpebral conjunctivitis, Coxsackie virus, measles, TB, Epstein-Barr virus, cat scratch disease, lymphogranuloma venereum, bulbar conjunctivitis, leptospirosis if sparing the limbus, Kawasaki disease, petechial conjunctival hemorrhage in infective endocarditis, uveitis in sarcoidosis, JIA, SLE, Kawasaki disease, Behçet disease, vasculitis, chorioretinitis in cytomegalovirus, toxoplasmosis, syphilis, proptosis, orbital tumor, thyrotoxicosis, metastasis in neuroblastoma, orbital infection, Wegener granulomatosis, idiopathic intracranial hypertension, lack of tears and absent corneal reflex in familial dysautonomia, failure of pupillary constriction, hypothalamic dysfunction, dysfunctional of the sphincter constrictor muscle of the eye. Skin and nail examination, nail fold capillary abnormalities, a dropout of capillary end loops, dilated tortuous capillaries in connective tissue disease such as juvenile dermatomyositis and systemic scleroderma, petechia, subcutaneous nodule, splinter hemorrhage, clubbing, vasculitis, infectious endocarditis, oral cavity, recurrent oral candidiasis, various immune deficiency, smooth tongue with the absence of fungiform papillae, familial dysautonomia, hyperemia of the pharynx, Epstein-Barr virus, cytomegalovirus, toxoplasmosis, salmonellosis, tularemia, Kawasaki disease, and leptospirosis. Rectal and genitourinary exam, lymphadenopathy or tenderness can indicate deep pelvic abscess, iliac adenitis, inflammatory bowel disease, or pelvic osteomyelitis. Musculoskeletal, point tenderness over a bone in osteomyelitis, neoplastic bone disease, or JIA, tenderness over trapezius muscle, subdiaphragmatic abscess, hyperactive deep tendon reflexes in thyrotoxicosis. Finding impaired weight gain or linear growth, significant collagen vascular disease, malignancy, and inflammatory bowel disease. Finding toxic appearance in Kawasaki disease. Finding conjunctivitis, significant Kawasaki syndrome, Kawasaki disease, if limbic sparing, adenovirus, and measles. Finding ophthalmological examination, papilledema, consider CNS mass lesion, uveitis, consider TB, systemic lupus erythematosus, Kawasaki, and sarcoidosis. Finding pharyngitis, significant Kawasaki, Epstein-Barr virus, cytomegalovirus. Finding tachypnea in subacute bacterial endocarditis, pneumonia. Finding rales in histoplasmosis, sarcoidosis, coccidomycosis. Finding cardiac murmur, gallop or friction rub, subacute bacterial endocarditis, acute rheumatic fever, and pericarditis. Finding hepatosplenomegaly in hepatitis, Epstein-Barr virus, cytomegalovirus, ehrlichiosis, anaplasmosis. Finding of arthritis in JIA, inflammatory bowel disease, and acute rheumatic fever. How to approach the child with fever of unknown origin. Obtain complete history, detailed fever history, duration, height, pattern, measurement technique, past medical, surgical, social history, medication, review system, perform complete physical examination. Is there travel or other exposure symptoms or physical examination signs suggestive of a specific disorder present? If it is no, patient using or exposed to medication or drug. If it is yes, this is drug fever. If it is no, perform a preliminary lab evaluation with complete blood count with the differential and smear, ESR, C-reactive protein, blood culture, urine analysis, urine culture, blood urea nitrogen, creatinine, liver function test, HIV, chest x-ray, tuberculin skin test, and interferon gamma release assay. Consider serology for Epstein-Barr virus, cytomegalovirus, brucellosis, tularemia, Bartonella hensea, Cassicrash disease, Salmonella typhi, leptospirosis, toxoplasmosis, and hepatitis. If there is abnormality, abnormal white VC, abnormal smear, either malignancy, Epstein-Barr virus, cytomegalovirus, malaria, and other parasite or relapsing fever. If there is thrombocytosis, atypical Kawasaki disease, positive urine culture in UTI, abnormal serology, cytomegalovirus, Epstein-Barr virus, typhoid fever, leptospirosis, brucellosis, tularemia, thrombocytopenia in malignancy, SLE, and viral infection, positive blood culture, bacteremia, endocarditis, abnormal chest X-ray, pneumonia, pleural effusion, sarcoidosis, tuberculosis, malignancy, pleuritis, pericarditis, infectious, and rheumatological. If it is a normal lab result, reconsidered or factitious fever or a resolution of fever, consider additional evaluation, serum ANA, serum immunoglobulin, serology, if not already done, consult infectious disease, other investigation, X-ray, sinus, mastoid, abdomen, white VC, scan, gallidium, indium, immunoscintigraphy, bone scan, liver, spleen scan, PET scan, bone marrow biopsy, differential diagnosis, JIA, SLE, polyarteritis nodosa, osteomyelitis, abscess, intra-abdominal, liver, perihepatic, inflammatory bowel disease, malignancy, hereditary periodic fever syndrome, auto-inflammatory disorder, immune deficiency. If there is a travel or exposure symptom or physical sign suggestive of a specific disorder, is there exposure to wild or domesticated animal? Zoonosis disease like cat scratch disease, tularemia, salmonellosis, brucellosis, leptospirosis, Q fever, rat white fever, cicatosis, toxoplasmosis, visceral larva migrans. If there is rash or petechia, Lyme disease, JIA, acute rheumatic fever, endocarditis, dermatomyositis, SLE, Kawasaki disease, Rocky Mountain spotted fever, histiocytosis, serum sickness, tularemia, Epstein-Barr virus. Is there travel or exposure to person recently traveled? Differential diagnosis, coccidomycosis, histoplasmosis, malaria, blastomycosis, Lyme disease, Rocky Mountain spotted fever, tuberculosis, ehrlichiosis, babesiosis, typhoid fever, and other endemic disease. ENT or respiratory symptom, sinusitis, pulmonary disease, pneumonia, TB, abscess, sarcoidosis, ANCA-associated vasculitis like Wegener granulomatosis, Epstein-Barr virus, cytomegalovirus, mycobacteria, mastoiditis, malignancy, typhoiditis, ingestion of contaminated food or milk or pike, visceral larva migrans, toxoplasmosis, salmonellosis, brucellosis, and rat white fever. Continuation. Is there weight loss or impaired linear growth, non-specific abdominal complaints, diarrhea, differential diagnosis, hepatitis, inflammatory bowel disease, abscess, intra-abdominal, hepatic, malignancy, enteritis, various pathogens could cause it, diabetes insipidus, central or nephrogenic. Abnormal cardiac exam, encarditis, rheumatic fever, endocarditis, JIA, SLE, viral pericarditis, and myocarditis. Bone, joint, or muscle problems, osteomyelitis, malignancy, trichinosis, dermatomyositis, polyarteritis nodosa, arboviral infection, hereditary periodic fever syndromes, autoinflammatory disorder. Recurrent fever with the periods of oneness in between, hereditary periodic fever syndromes, autoinflammatory disorder. Other physical abnormality, neurologic, cutaneous, dental, orthopedics, differential diagnosis, ectodermal dysplasia, CNS hypothalamic disorder, infantile cortical hyperostosis, hereditary sensory and autonomic neuropathy, familial dysautonomia, hereditary periodic fever syndrome, autoinflammatory disorder. Top tips. Factitious fever, although rare, it is an important cause of pyrexia of unknown origin. Incidence 1 to 2% of causes of fever. Measurements of temperature by a nurse attending to the procedure is essential to eliminate the rare possibility. Fever of neoplastic origin usually does not respond to antibiotics such as paracetamol, but it does respond to indomethacin or naproxen. Naproxen causes a prompt complete lysis of the neoplastic fever with the sustained normal temperature, which is called naproxen test. Naproxen is therefore useful in the differential diagnosis between neoplastic and infectious fever. High index of suspicion should be kept for diagnosis of Kawasaki disease. Empirical therapy should be avoided as far as possible. The diagnosis often evolves with time and patience is the key. Tuberculosis serology has no place in the diagnosis of fever of unknown origin. Red flag. Although viral infection account for the vast majority of causes of fever, 90 to 95%, children younger than 3 months of age with the immune deficiency, HIV or an chemotherapy, sickle cell anemia, cystic fibrosis, acyclemia, and with the body temperature higher than 40 Celsius should be considered as having bacterial infection until proved otherwise, and treatment with the antibiotic should be commenced without waiting for laboratory result. Always remember that normal body temperature does not preclude serious bacterial infection. Infants younger than 3 months of age and ill-appearing infant and children should be hospitalized, their urine and blood culture, and they should receive IV ceftriaxone or cefotaxime. Those with fever higher than 39 Celsius should be screened with the blood white PC and C-reactive protein. Peers and pitfall. The cause of pyrexia of unknown origin is more often a common disease presenting in atypical fashion than a rare disease presenting in typical fashion. Careful and repeat history, physical exam, and review interpretation of lab data usually help to determine the cause of fever of unknown origin. In a small number of cases, it may not be possible to arrive the etiologic diagnosis. In such cases, periodic reassessment should be done as the disease may finally surface, like lymphoma, systemic onset, JIA. Some cases of fever of unknown origin may self-resolve over time. Thank you for your listening.